Okay, great. Assalamu alaikum and good evening, good afternoon, everyone. It could be good morning to you, good afternoon, good evening, and welcome to this last series or last session of the Altogether Better Health Reinvented by Interprofessional.Global and hosted by Qatar University. So this session is being organized through the Arabic-speaking network for interprofessional education and the Indian Interprofessional Education Network. And moderating this session is myself. I'm Alla El-Awaisi. I'm the Assistant Dean for Student Affairs at the College of Pharmacy, and I'm the QU Health Chair of the Interprofessional Education Committee at Qatar University. Suzanne, would you like to introduce yourself?
Yes, thanks, Alla, and lovely and nice to see everybody here, and welcome to this session. I'm Susan Waller, and I'm Assistant Professor in the Department of Medical Education at the College of Medicine and Health Sciences at the United Arab Emirates University in the UAE. And yeah, lovely to see you all, and wish our speakers the best with their presentations.
Yeah, very much looking forward to a very exciting and different topics of presentation around interprofessional education and collaborative practice. Just to give you an idea about Qatar University Health. So the vision of QU Health is to be recognized regionally for excellence in interprofessional education and interdisciplinary research, a first choice for student and scholar, and a national catalyst for innovation in the field. And under the QU Health, we have 4 different health colleges: College of Pharmacy, College of Health Sciences, College of Medicine, and College of the Dental Medicine. So the colleges work collaboratively together to achieve their mission and vision. Interprofessional.Global, as you can see, it's the web address. You can, this is the link. So it's you can just put interprofessional.global, and it's a global confederation for interprofessional education and collaborative practice. The vision for Interprofessional.Global is to achieve better health for all through interprofessional education, practice, and research. And the mission is to serve as agents of change, providing global leadership in advocating for, collaborating on, promoting, developing, and researching interprofessional education and collaborative practice. And there are various networks around the globe, as you can see, in various regions. And within this, the ATPH Reinvented series, the different networks have worked together to come up with this series of webinars. And today is the session 8, and it's the last seminar, last session within the series. As I said, this is being hosted or organized through the Arabic-speaking countries, which is an emerging network within Interprofessional.Global. And we've just had our first meeting a couple of weeks ago, and that was a picture of a very productive meeting with quite a lot of plans for the future ahead. And also, this is done in collaboration with the IndIPEN, the Indian Interprofessional Education Network. If you're interested to join the Arabic-speaking network, please join. You can email us at ipic@qu.edu.qa. So coming back to the ATPH 10 Reinvented webinar series. So as you know, the Altogether Better Health, the 10th edition of it was meant to be hosted in Qatar in 2020. But unfortunately, COVID hit us all hard around the globe. And members within Interprofessional.Global, they felt that there is a need to try to keep the conversation going until we meet again in person in 2023. So you can have a link, you can access the link for books of abstract of the different abstracts that have been presented. There will have been a total of 25 presentations, including today. Just a couple of housekeeping. Today's session, as you know, it's been recorded and will be available post the session. So we'll be sharing with you the link. There are two ways to ask questions. So you can either ask a question directly after the presentation, or you can ask questions towards the end. You can also use the chat feature in WebEx, or you can raise your hand and we can ask you, to ask your questions. Sorry, Suzanne, I remembered that this you were going to start here, so the mic is yours.
Yes, thank you. That's fine. Thanks, Alla. We'll go to the next slide, I think. So everyone can see this is our plan for timing today. And as Alla was saying, our speakers are going to speak for about 20 to 25 minutes, and then we will have some time for questions after each presentation. But we will also have questions at the end. So please put your questions in the chat or raise your hand, as Alla said. We've got a little bit of a change in that we're going to start the presentation with the second speaker on the timetable that's been shared with you today. And then we will have our third, and then original first speaker will be after that. So thanks everybody for joining us here today. We will start with introducing our first speaker. And our first speaker will be Dr. Lulu Sherif, and she's Professor of Anesthesiology and Head of the Department Healthcare Simulation Education at Father Muller Medical College, Mangalore in Karnataka and in India. And Dr. Lulu is going to talk to us about simulation-based interprofessional education to enhance teamwork and communication skills amongst medical and nursing students. Dr. Lulu's completed her fellowship at the Manipal FEMA International Institute for Leadership in Interprofessional Education and is presently pursuing the second year of her Master's in Healthcare Simulation and Patient Safety at the National University of Ireland in Galway, Ireland. Dr. Lulu is the first applicant from India to get certified as an advanced healthcare simulation educator from the Society for Simulation in Healthcare, and has been serving as a member of the certification subcommittee of that society since the last 3 years. Dr. Lulu is an executive board member of the Society for Healthcare Simulation India and Vice Chair of the Operation Board of the International Journal of Healthcare Simulation Advances in Theory and Practice. Dr. Lulu's special interest is in advancing the field of simulation-enhanced interprofessional education. Thank you, Dr. Lulu. We look forward to your presentation. Over to you.
Thank you so much, and I'm really humbly privileged here for selecting our abstracts and giving us a chance to present. So I'm going to share my screen right now. I hope my screen is visible. Yes, and I'm audible. The $1 million statement, am I audible? Okay, yes. Thank you so much. So it's really a privilege to be here. I was in Qatar a few years ago. Me and my husband were there. My husband worked in Hamad. My brother is still there. So it's kind of, a second home for us. Now, I will take the next 20 minutes just to brief you on what we are doing here. On the topic of simulation-based interprofessional education, specifically to enhance the teamwork and communication skill among the medical and nursing students in our institute. So thank you for the introduction. Moving on, this is just a color vibe of where we belong. I'm from Mangalore, a coastal city down south in India. And we have a lot of color, culture, food, everything available. So if you happen to come to Mangalore, please do contact me or Supriya. Both of us are from the same town. Yes. So no conflict of interest to disclose. Whatever simulator we have used or whatever I'm sharing here, no financial disclosures. And I do not endorse any of those simulators. And for all the tools I have used for this study, copyright permission was obtained. So what I aim to achieve is to give the audience an introduction to interprofessional education and simulation-based education, and also to provide evidence of how simulation is a strategy for enhancing interprofessional education, and towards the end share our experiences of pioneering a module using the team steps framework to improve communication and teamwork among our medical and nursing undergraduates. So most of us here are advocates of interprofessional education, and we do know that we need to learn with, from, and about each other so that we can achieve all the quadruple aims that were set forth with better outcomes, patient safety, increased clinical experience for the practitioner, and definitely cost effectiveness. So there are a lot of literature mentioning that IPE is essential to promote patient safety and definitely to decrease errors in healthcare. And even out of all our clinical practice, we do observe, the lacunae and the latent gaps involved just because, our professionals do not know how to work with each other. And why? Because we've never taught them how to work with each other during their undergraduate period. So following the competencies of what we want to achieve, exactly the timing of where we want to achieve them, so that before they come and work together, they are aware, of what each other's roles are, what are the values of each other's professions, on how to communicate, how the teamwork. So these competencies need to be taught during their undergraduate or their postgraduate period before they enter the workplace, so that there is enhanced collaborative practice. And based on all the instructional strategies, suggested to be included in the IP curriculum, simulation plays a huge role, especially when you cover, most of the competencies here, whether it's advocacy of role clarification, whether you want to include the patient and family-centered approach, communication, shared decision-making, coordinating care, most of the competencies we're talking about, to an extent, can be, imparted using simulation. So now just moving on to what is simulation-based education, a lot of definitions available everywhere, but I've just captured a few to highlight and let you know that it is any educational intervention that replicates a clinical environment. And what is our goal? Why are we doing it? It is for education, training, assessment, or even for research. And just to make it very clear, it is a technique of training or education, and we want to take the focus out of the technology. And what domains can we cover using this very potential teaching tool? A wide range of modalities we have to teach: the cognitive domain, the psychomotor skill domain, and definitely the affective domain. So all these domains are a part of our IP competencies, and that is why we advocate simulation-based method to use for the IPE. Various modalities are available. Just one slide to tell. We use a lot of part task trainers. Those are, half body mannequins, or the head phantoms for the dentals, or, an IV arm or a pelvic part task, or the full-fledged high-tech simulated simulate patient simulators. Very effective modality is our simulated participants, also known as standardized patient. Terminology is moving to simulated participants and patients more, and also our virtual or computer-based modalities. Using all of them, one or two, combining them, we use for hybrid simulation. And what are the core competencies that can be incorporated in all our lesson plans, and what do we achieve in our objectives? All these competencies mentioned here, and going to the last one, definitely our IPEC competencies. This is adapted from Bristol Medical Simulation Center, this design, because I have done my masterclass there. So how do we start out with? start with our needs assessment and, outline what we need to do in the simulation course. We plan the scenario progression. We decide, okay, now when the participant, when we immerse them in the simulation, if the participant does this, we make the scenario move just like a storyboard or a script. And if the participant does not do this, we worsen it, or, we bring about in our script on how we can let them experience. So this, going back to the educational theories, simulation uses both the adult learning theory, the experiential model of COBS. So based on that, we plan our scenario states. We make sure that there is an amount of realism. That doesn't mean we need to pay for the high-tech simulators. We can as well do it with a hybrid, a faculty voice with a part task trainer, which can achieve, more of the effective domain when compared to a high-tech simulator. We complete and write a story script. We dry run it, we practice it, we use all the resources available, and then we implement it and also plan for the assessment strategy on how are we going to assess that our learners have achieved the goal we have set them for. So this is basically how we do a simulation scenario design. When the participants come to us, we brief them on what to expect, what the scenario is, what the context is. We set a few ground rules, especially to maintain their psychological fidelity. We give them, a confidentiality agreement, and we tell them to treat this scenario as a real event so that learning can happen. Then we immerse them. Then we bring them back to debriefing, and this is where most of the reflective learning takes place. They actually reflect on what they performed, whether they are direct participants or observers, and through that reflection, they kind of unlearn or relearn, the important concepts, and then we have an evaluation. So this is basically a simulated clinical experience. So just to give you a brief on how are we going about it. So now when we come back to simulation enhanced interprofessional education, it is nothing but we are overlapping both the pedagogy of simulation and IPE. And what are we trying to do here? We're using the simulated experience to achieve the interprofessional competencies. So you can do it in either ways. You can use simulation to teach them the IPEC competencies, as well as you can take the part of simulation to teach, in a trauma scenario or a labor room scenario where everyone is working together and you have the set of trauma goals to achieve or the obstetric goals to achieve. So Sim IPE is the overlap of simulation and IPE. And though we all know that interprofessional education has been identified by a lot of accreditation agencies, and it is a must know by the students now to learn these IPEC competencies. At the same time, participating in Sim IPE has also demonstrated improvement in the acquisition of knowledge, skills, attitudes, and behaviors of teamwork, which is required to improve quality of care and to reduce the healthcare errors. So with this background, we want to achieve Sim IPE. And how do you go about it? It has to be based on some educational theories. You have to follow the best practices, and we at our institute and most centers follow the INACSL standards of best practice for planning and implementing a Sim IPE session. And at the same time, local context, what are the institutional goals, to your community goals, address it, and definitely have an evaluation plan. So with that, a brief overview on what was IPE and what was simulation-based education, I'm moving on to sharing our experience on how we developed this module. So the background is our nursing students and our medical students. During the undergraduate years, are learning in silos. We have no formal interprofessional education as a part of our curriculum. And with that background, we decided to evaluate IPSE module for specifically for teamwork and communication. So we set out with the objectives of assessing what the attitudes of both, not just our students, but also our faculty, if we introduce this. So we wanted to assess their attitude and perception towards this module. And we wanted to immerse them in simulation and assess their teamwork and communication, and see if simulation is a potential tool to enhance these competencies, and also to appraise the need of making it mandate for such a module to be introduced into the curriculum. So we formed an IP team members. We had around 10 to 12 faculty who were simulation educators, both from the medical and nursing side, who helped us with the scenario development and evaluation. Definitely, we required the administrative support for not just the authorization, but a huge challenge over here was for scheduling. The students had such a tightly packed curriculum that we needed to schedule it. And for this module, I had to even get them on Sundays, and I had to change it a little bit to record so that the faculty can view the recording and assess it. So there was a huge challenge faced during the scheduling. And definitely we had the medical and nursing intern coordinating with us for the scheduling. So how did we go about it? It was a mixed method design for this module, performed at the Simulation and Skills Center with the help of the statistician, who were our target audience, medical and nursing interns at their final year. How did we go about it? So first, initially, we sent out a survey. And all the tools I used here, mentioned here, like the KICSIM attitude or the Washington University IP toolkit or the Team Step AHRQ Team Step framework, IPEC competency tool, and the socialized the ISVS of the survey. Everything was taken. I've not changed anything because we were doing it for the first time. So now we feel that these tools we can based on our context we can make our tools and validate it, but that was kept for a later date. But we kind of use these tools. Initially, the survey was done with the KICSIM attitude. We got the perception and attitude of both the faculty and the learners. As we conducted it in 2 sessions, we had 40 students who volunteered for the later part of the study. We made it in 2 batches, so 20 students. The ratio of nursing to medical was 3:2. We got them inside. We threw them into an immersive scenario. We used only trauma simulations for this. And we took their performance in the simulation as a pre-test. And then we also made them have a self-assessment using the IP toolkit on how they felt, and that was considered as the pre-test. During the phase 2, we introduced them to the IPEC competencies. We introduced them to the Team Steps framework, and following that, we put them back into simulation again and assessed them on their performance of teamwork and communication, and also made them do a self-assessment on how the training was and about the IPEC competencies. This formed our qualitative data. Pre and post intervention, and how we took our qualitative data was through written reflections, as well as we through consent. After consent, we recorded the debriefing, and then we did a thematic analysis of those audio debriefings. And after 2 weeks, we give them a self-assessment on the interprofessional ISVS scale to see how if their behavior or attitude had changed post this training. So these are the tools used. If anybody wants to know or wants more information, please do contact me. I've put my email at the end. So these are the demographic data. We had participants who had very less prior simulation experience with, or nil with interprofessional, but simulation, yes, because our students do come to the simulation center. And as part of that, they do undergo the communication skill training. Based on the KICSIM attitude score, the faculty had a more positive attitude, probably because they were exposed to it when compared to our medical and nursing students. We assessed their performance after immersing them in the simulation using the Team Steps TPOT score, and there was a significant improvement pre and post test on these following competencies as based on the Team Steps framework. And on their self-assessment before the training and after the training also, we have seen improvement in scores, both with their assessment of how the simulation helped them, as well as using the communication tools like ISBAR or 2-challenge rule or CAS, and as well as forming the roles clarity and also the attitude and values towards the other professions. Similarly, we did have a significant improvement in their self-assessment on how they are able to work with others and how they are able to have a shared problem solving and their attitude towards interprofessional teamwork. And this was also after 2 weeks, 86% almost had, they said they valued working with others and they were comfortable and they wanted to apply. And during the qualitative analysis, most of them, majority of them said there is a need for introducing interprofessional simulation into the curriculum. They were very impressed with using structured tools like ISBAR, and they were aware of each other's roles during the simulation. What the nurse is supposed to do, what the physician is supposed to do. So based on just coming to the discussion on what outcomes we achieved with this small module, and what is reported in literature. So there is ample literature to show that most of the participants engaged in SIM-IPE report perceived improvement in reasoning, shared mental model, communication, collaboration, awareness of how effective IPE is. And they do understand the roles of other professionals and awareness of not just the professions, but also patient-centered, like how important the patient and family members are. So that was something which we didn't capture, the patient and family part of it. So coming to what our challenges were, like I mentioned, scheduling sessions, but our enabling factors were the enthusiasm and, a very proactive stakeholders. We did achieve improvement in communication and attitude towards the interprofessional simulation module. And what we wanted to achieve is try to integrate this module into the curriculum. So what I have presented here is not, it's basically to let you all know that, it is feasible. And through networking and through collaboration lessons, what we learned is can help us facilitate to implement this module in the undergraduate curricula, especially in our Indian context where we do not have any formal IPE training. So with that, I conclude what we achieved was in enhancement in communication skills, role clarification, and teamwork. Thank you so much. And my email is here if anybody would like to contact me. Open to queries.
Thank you very much, Dr. Lulu. Amazing evaluation. We've just got a couple of minutes, so is there anyone who would like to ask a question? If you'd raise your hand, please, and you can be unmuted.
Thank you very much, Dr. Lulu. This is a really great, comprehensive presentation.
Thank you.
Thank you very much. I have a question now. The tools used in simulation in your survey, and this, it will be different than if it was work-based study?
Yes. So what I have used is actually, I've not, that is one limitation of my study. So I have not assessed the workplace-based assessment. So these are interns who are working in the unit, and I have not used workplace-based assessment at all for these. These are more of self-assessment by the learners and not a direct observation of how they performed in the work area. So that is one limitation of this study.
But you really seems to use a lot of tools.
Yeah, and that was a challenge actually, because towards the end, the learners had so many forms to fill. And I think next onwards, I need to, kind of make it a little more comprehensive, because it was a new arena where we are stepping into. I didn't want to, change any validated tool. So I thought we'll use some pre-validated tools and then see how the outcome is, and then go ahead, to validate our own tools and use our own tools.
And the tools used is already published before pre-validation?
Yes. So literature is available. Yes. So
would you mind to share with me? I will email you after this.
Yes. I would give you all the tools and the references and everything.
Great. Thank you very much.
Not a problem. Yes. Thank you so much.
That's wonderful. That's one of the wonderful outcomes of these sessions, is collaboration amongst the participants. So thank you, Dr. Lulu and Dr. Ahmed.
Thank you so much, Susan.
Yeah, wonderful. We might go ahead and then we can have any other questions for Dr. Lulu at the end, if that's okay. You'll stay with us?
Yes, I'm here.
Wonderful, that's good. So we'll just bring the slides back on, Alla, please. So our next speaker will be coming up on your screen now, and this is Dr. Supriya Nambiar. And Dr. Supriya is the professor and head, as you see, in the Department of Orthodontics and Dentofacial Orthopaedics at the Manipal College of Dental Science in Mangalore, and that's affiliated with the Manipal Academy of sorry, I just lost the slide. Manipal Academy of Higher Education, apologies. Next slide, please. So as we're saying, Dr. Supriya completed her undergraduate degree in Bachelor of Dental Surgery from Government Dental College, Calcutta, under the University of Calcutta in Kerala. Calicut, sorry, I beg your pardon, Kerala in 1996, and has a master's degree in orthodontics and dentofacial orthopedics from Manipal University, Karnataka in India, in the year of 2010. Doctor is a FAMA fellow from MPhilip, which is the IPE organisation in Manipal, from the 2008 batch. Dr. Supriya holds a certificate in bioethics from the Centre for Bioethics, Manipal, and a certificate in biostatistics and research methodology from Prasanna School of Public Health, Manipal. Doctor is also holding a postgraduate diploma in medical legal ethics from the National School of Law, Bangalore, and is currently pursuing her PhD from the Centre for Doctoral Studies in Manipal under the Manipal Academy of Higher Education, Manipal. And Dr. Supriya is going to speak to us today about enhancing competencies amongst health professions for primary prevention in oral healthcare using an interprofessional approach. Over to you, Dr. Supriya.
Thank you, Dr. Susan.
Thank you.
Am I audible?
Yes, good. Yes, we just have your screen sharing.
Good afternoon, everyone present here, and my greetings to the moderators for today, Dr. Alla El-Awaisi and Dr. Susan Muller. And I wish to thank Qatar University and its interprofessional education sector for giving me this opportunity to speak at this forum. Thank you so much for the acceptance. And also I wish to thank Dr. Susan for the kind introduction. Thank you.
Welcome.
Yes.
Can you share your screen, Dr. Supriya?
I'll share my screen now.
Great, wonderful.
Is it visible?
Yes, it's coming up now, yes, and onto the presenter mode. Wonderful, that's great, thank you.
Thank you. First and foremost, I would like to compliment my fellow speakers for today, Dr. Ahmed Al-Hamadi and Dr. Lulu Sherif, who spoke brilliantly on simulation in IP environment. I'm Dr. Supriya Nambiar, Professor and Head Department of Orthodontics and Dentofacial Orthopaedics, MCODS-Mangalore, belonging an affiliate of Manipal Academy of Higher Education. And today I would like to present my experiences on the My FAMA project, which I had done with MPhilip Manipal. So that's on enhancing competencies among health professional learners for primary preventive oral healthcare and interprofessional approach. So basically, it is about integration of oral and overall healthcare by bringing in an interprofessional group of healthcare learners and trying to bridge the gap between oral and systemic healthcare. We all work in our own silos, and it is almost as if the mouth is not part of the human body. So that's how the clinical examinations proceed in a hospital environment. So incorporating the involvement of different healthcare learners together in an interprofessional environment will go a long way in bridging the gap. And that was the most important idea behind this project. So this was undertaken as part of a FAMA project in 2018 to 20 period. And you can see the picture of Manipal University and on the top. And this project was undertaken under the guidance of Professor Soumendra Sahu, who is a professor at Manipal Malacca Medical College, Malaysia, and Professor Siraj Ali Mohammed, who is with Manipal Malacca Medical College, Manipal, and so is also the director of Manipal Famer Institute. So in the current times, these are times of pandemic, and we have listened to a lot of news about the pandemic. And we have heard that COVID-19 has been responsible for almost 3 million deaths, but not just due to the COVID infection, rather because of the disruption that has been caused to the healthcare service delivery and routine immunization, fewer people seeking care, and also shortages of funding for non-COVID services during these times. So there's been a disruption in healthcare governance actually, and but the positives at these pandemic times has been signals of teamwork, largely in the intensive care context. And we have heard often these words like we're all in this together, camaraderie is everything. The importance of team has been emphasized during these times, especially with critical members like respiratory therapists, cleaners, physicians, nurses, all working in and pitching in for each other during these times. These have been emergency times, and we have also seen a lot of role changes occurring, such as rapid deployment of staff from other departments to critical care. And all these have been increased emphasis of teamwork, which has been presented to us during the last couple of years. So the extent to which the lessons that we have learned during these times can be carried over in future remains to be seen, rather. So we know power hierarchies in healthcare are very common to every health system in every country. And we have seen these power hierarchies breaking down during these pandemic times. So we can actually increase interprofessional collaboration by educating all the healthcare learners and other health professionals by retraining them at the work environment for more interprofessional collaboration. So interprofessional collaboration strategies which we can undertake are encouraging social interaction through small events or workshops, use of team building exercises, and breaking down office silos or breaking down working environment silos like dentistry in the dental colleges. So in a hospital environment, usually what we see is referrals to the dental section, but that is just to see what is happening in the mouth, with not even an examination happening at the medical side. So these kind of breakdown of silos is very, very important, in addition to the breakdown of power hierarchies for better outcomes. So IPE basically, according to World Health Organization, by implementing interprofessional collaboration and learning to work together, we learn to respect one another's perspectives in healthcare. This is an environment wherein multiple disciplines can work more effectively as a team to help improve patient outcomes. So here in IPE, healthcare learners learn with, from, and about each other. And the importance of these prepositions is we know that it is about active and interactive learning. So it is not just a mixed group of people acquiring the same knowledge or developing the same clinical skill. That's what happens in our universities. They have different kinds of learners, but it is how they interact with each other during the learning environment. So we all are very familiar with what these from, about, and with is about in IPE. Basically, it's about from is about earning trust, respect, and understanding each other's roles and responsibilities. And also how do we do it? By active engagement, co-location, teamwork, and collaboration. So a better team of experts usually doesn't mean an expert team. Usually team function most efficiently when members share a common understanding of each other's roles and responsibilities. And usually experts have to learn to work and play together. And having prior experiences of collaboration is very, very helpful. So rather than putting a person into an IPP or interprofessional practice without prior involvement in interprofessional education is not good. It will not have the same outcome if the learner undergoes an interprofessional education system rather. So which this interprofessional education always leads to more collaboration, leading to less duplication of less confusion, less disappointment, frustration, and greater productivity. So these are some of the benefits of interprofessional collaboration, which I need not emphasize further. But our ever-changing healthcare system is giving us a lot of complex health needs for patients, especially what we have seen during this pandemic, wherein a lot of interprofessional work had to be done at the work environment and impromptu rather. And it also required a lot of innovative and efficient modes of patient care. So all these requires effective communication, teamwork, and collaboration among healthcare professionals. So basically, we need to have assimilation, immersion, and competencies for a good IPE learning experience. So what is the role that the patient have in the team in healthcare practice as well as in education? Patient is always in the center of the team. And this patient-oriented healthcare delivery will be better if multiple learners are together and each person understands the other person's perspective on the patient care rather. So according to the World Health Organization, by implementing interprofessional collaboration and learning to work together and respecting one another's perspectives in healthcare, multiple disciplines can work more effectively as a team to improve the health outcomes. So interprofessional education occurs when students from two or more professions learn about, from, and with each other to enable effective collaboration and improved health outcomes. So once students understand how to work interprofessionally, they are ready to enter the workplace as a member of the collaborative practice team. So this is a key step in moving health systems from fragmentation to a position of strength. And this formed the basis on which we developed the module wherein we thought of bridging the gap between oral healthcare and systemic healthcare. So everybody is familiar with this picture or the WHO framework on IPE, and all these are depending on the jurisdiction of the particular area. In India, clinical, as Dr. Lulu has mentioned, simulation is in the nascent stage. And also a lot of the educational context happens in silos. There is absolutely no IPE happening in the Indian context rather. So to introduce it was not very easy. So to present whether we were prepared for it, absolutely no. How well are we from the dental education clinical side to communicate with the medical and allied health clinical side? Very, it was very, very difficult because we never understood the challenges that were there. especially with scheduling and the curriculum or navigating the curriculum was the most difficult task. So we were not prepared for the module rather. But we worked around it, got all the stakeholders on board, even though it was a tough task, got everybody together. We were able to convince the administrators and went ahead with the project. So in this interprofessional educational module that we had, we had to understand whether it was really necessary or not. And for that, we had to do a needs assessment before undertaking the project. So we know more than 90% of all systemic complications have oral conditions also. Oral lesions present very early, and these oral lesions can result in early diagnosis in most of the systemic cases, or systemic conditions will have some oral complications which either of the health workers can miss. So the connection between oral health and overall health had to be emphasized to all healthcare learners in this project. So integrating oral health into general health, it helps to make it more acceptable to the community, thereby giving a comprehensive patient care. And primary health level workers in India, as well as, I don't know about the other healthcare scenario, but in India, most primary healthcare workers and medical doctors do not have adequate knowledge about oral hygiene and prevention of oral diseases. And health professions, education and practice in India, like in other parts of the world, have always been and continues to be in silos. So increased collaboration was the need of the hour. And the strong correlation between oral diseases and non-communicable systemic disease, usually due to several common risk factors, and many general diseases have oral manifestations. So basically, the bridge or the gap between the comprehensive patient care was a lack of acknowledgement of the importance of oral health, perception of oral health as secondary to systemic health, and no access to oral health providers due to especially at the primary health centers, and dental treatment being unaffordable, and the quality of dental treatment also varied between the centers. So this was a scenario in India. So in such a scenario, medical professionals play a very crucial, and the allied health personnel play a very crucial role in actually, they are the key personnel at primary health centers, and they can play a very important role in improving the overall health of patients because of their knowledge as well as clinical day-to-day experiences. So they encounter a lot of oral health problems among patients, but never do they correlate it with the systemic conditions. Rather, if there is an oral problem or oral health problem or oral lesion, that is sent to a dentist, which never gets connected to the systemic problem, rather. So to improve the awareness regarding this, we undertook this project to impart knowledge and introduce IP collaboration among healthcare learners from different sections of the healthcare learners. That is, the main objectives were to assess the knowledge and attitude towards collaborative framework for primary prevention in oral healthcare among the medical professional as well as the other healthcare learners. So the interprofessional team that we had included administrative personnel, dental faculty, the medical faculty, and nursing students, medical students, and social work students. So earlier, any IP project which I had seen, social work students who are actually the community level workers were never included. It was, there were a lot of projects in India which included the ASHA workers, and that is the community service community workers rather, but the social work students were never included in such IP work. So We went ahead with getting permission from the organizational head and the institutional ethics committee. And the study setting was the Manipal College of Dental Sciences, Mangalore, Muller Medical College, Mangalore, and Roshni Nilaya for the School of Social Work, which are all the academic institutions at Mangalore. The resource faculty were selected from the institutional faculty at Manipal College of Dental Sciences. And before we proceeded with the project, we did a needs assessment among 80 medical doctors at Mangalore, and they were given a Google form questionnaire regarding the need for the study to assess what their perception was regarding this IP project. So the teaching modules were designed based on the existing teaching modules that was designed by the National Health and Family Welfare Institute, as well as Indian Council of Medical Research and All India Institute of Medical Sciences, New Delhi. So they had an existing model which was formed the basis for our module with certain key areas of focus, especially with regards to oral healthcare. And the module was externally and internally validated. And also from the themes that were developed from the needs assessment, we developed pre and post questionnaires, which were again externally and internally validated. So pre and post question awareness sessions were done on the said IP students. Pre and post sessions, the objective assessment was done using pre and post questionnaire. So the results of the assessment showed that the needs assessment study gave us a lot of positive response regarding the need for the study, and it was almost like 98% of the doctors mentioned it as the need of the time. And some of the comments varied from that it is going to initiate good relationship and keep the patients in a better way, to wherein comments like it's going to be challenging, needs time and resources. Yes, it was indeed challenging, and if successful, could help with early diagnosis. So these were some of the comments, and almost 99% of the healthcare practitioners felt that it was a need of the time. So post that, after the awareness sessions, what we have seen from the data was that most of the medical students were more aware of the oral health conditions, oral health lesions, and connection between systemic and oral health much better than the other healthcare learners. So this may be because of the curriculum that they have, the oral health lesions and systemic manifestations of it form a part of their curriculum. So or it is in detail in their curriculum rather than the other social work students and allied health students. So they formed that there was less difference between pre and post awareness sessions between in medical students than the other students. So to discuss what we had done, the strength of the project was that it gave an initiation of IP healthcare workforce trained in oral health. So we had a mix of different healthcare learners working towards connecting oral health and systemic health. And also it made them understand the positives as well as pitfalls of working in multidisciplinary environment, and also the pitfalls of working in silos. So basically the outcomes of this project has been that collaborative team-based approach to oral health was introduced to the healthcare learners, and also there was increased awareness and emphasis on IP in oral health, which as per the learners, it led to better patient care. The limitations and the challenges that we faced were mainly scheduling around the existing curriculum, and also time management, where to schedule classes for the awareness modules was not an easy task. To navigate around the administrative hurdles was a huge task, and that was the most important part of the study. Navigating around the scheduling problem was the biggest task here. So the message that we would like to impart here is that collaborative healthcare workforce leads to reduced dental disease burden. So it's always better for a medical person, along with the general examination, to have a oral health examination too, basics of oral health examination, so that any oral lesion which is present can be connected to the systemic condition of the patient and can lead to better outcomes rather, and also lead to early diagnosis. So the enabling factors for this project was my FAMU faculty and my colleagues, the administrative officials, the head of the institutions, and dental faculty and IP learners. And the impact has been on commitment, collaboration, coordination among the healthcare learners. Yes, this module that was developed can actually go a long way if it gets institutionalized as an elective for different healthcare learners. So, and it will also lead to bridging the gap between oral and systemic health. This again, once it becomes an elective, can also lead to a health policy level initiative to integrate it into the dental and other healthcare learners curriculum. So the conclusions of this project was that the need-based study elicited great enthusiasm for interprofessional collaboration from medical practitioners, some of them even terming it as the need of the hour for bridging the gap between oral and systemic health. And oral health awareness was the least among the social work students compared to the nursing students and medical students. And the extent of application of this knowledge in everyday patient care will have to be assessed in an interprofessional kind of case-based workshop rather, because this was just a awareness assessment that was done. So medical professional had adequate knowledge and a positive attitude towards a collaborative framework for primary prevention in oral health, which denotes an encouraging and favorable environment for future interprofessional projects in with regards to oral health. And the other interprofessional healthcare learners had varying levels of knowledge, but showed a positive framework of mind towards integrated and collaborative learning. So this project, if it gets accepted and institutionalized, will go a long way in improving the patient outcome. Thank you. Over to you, Dr. Susan.
Thank you very much, Dr. Supriya. You shared with us a very important part of our health that, as you have rightly pointed out, is often neglected in our curriculums and in our practice. We've got a couple of minutes. Would anybody like to ask a question at the moment? If you do, please raise your hand and your mic will be unmuted. So, Dr. Supriya, can I just ask you, please?
Yes.
I know that, you know, it wasn't the point of your evaluation, but did you get any feedback from the social work students about their reception of the education?
Yes, they were very keen to have participation in a case-based interprofessional workshop, which I will be taking up as part of my second phase of this project. So they were all very, very keen, because for them, they were not aware of at all about the oral health
Yes.
and what all can be done at a primary care level by
Yes.
other healthcare professionals. So
yeah, fabulous. And I guess it'd be in that case-based situation that they may understand their role
Yes,
in
absolutely.
supporting people's oral health. Yeah, fabulous. That's great. Any other questions for Dr. Supriya at the moment?
Thank you so much
Thanks,
for
Alla.
this really interesting presentation. Like you mentioned, about the plans to have this as an elective, course. What's, your thoughts? Because sometimes when people, view it as elective, they think it's optional, where in fact we want people to realize and understand that it is not it's not optional. Interprofessional education is part of our work. What's your thoughts on this?
Yes, Dr. Alla, thank you. Actually, in our institute here, we have medical students coming for a posting, 15-day posting as an intern to the dental section. But how seriously do they take that? No, the dental faculty, they don't take it seriously. So they just come, they are given the attendance rather, and they just observe what is happening, but they're not getting any first-hand information regarding what is the scenario, what is happening, what are the some simple things which they can learn. So these kind of things are not completely carried over to them rather. And that if I can get the institution to take it seriously, and that posting which is already there, which if something can be done there at that time, which is not an optional posting, it is a mandatory 15-day posting. So if we can start teaching them something during that time, it will go a long way. And if that example is carried over to other places, maybe it can get incorporated into the curriculum. But leaving it to the elective, yes, I agree with that. If it is elective, there will be people going on to the other segments rather than oral health. So it has to be it should not be optional, rather. It should not be an elective. Yes. But right now, I can put it as only as an elective.
Thank you so much, Dr.
Yes.
Supriya. I think we have, Susan, we have a question in the chat by Dr. Asma from CNAQ. She's saying, thank you, Dr. Supriya, for sharing your work. As you said, navigating the curriculum is still a challenge.
Yes.
I like how your IPE practice helped to discover some shortcomings in the curriculum of certain healthcare professions.
Yes, exactly. Thank you. Thank you so much. Because I am a person who is, we think of a patient as a whole rather than the oral health and systemic health separate.
Yes.
So it should be one, and a medical person should be able to see what is in the mouth because it's part of the body rather. So I, as an orthodontist, actually am away from the normal diagnosis and treatment for the oral lesions, but still, as a general practitioner from my BDS days, I still remember understanding relations and connecting it with systemic health. So I think a medical professional should also be trained to do that.
Yes.
At least the basics of oral lesions and oral hygiene maintenance, which goes a long way in the systemic health of the patient, rather.
Absolutely. Well, we know in chronic diseases like diabetes, we want doctors to, ensure that the person is having dental support and, that everything is very connected. Yeah. Wonderful. Thank you very much, Dr. Supriya. We will now move on to our next speaker. And if anyone's got any more questions, we can go to that at the end. So welcome. Our next speaker is Dr. Ahmed Al-Hamadi. And Dr. Al-Hamadi is the Division Chief of General Academic Pediatrics at Hamad Medical Corporation and Sidra Medical and Research Centre. And he's also Assistant Professor of Pediatrics at Muller Medical College in Qatar. And Doctor is going to talk to us today about effective communication and team collaboration in multicultural healthcare environments, the challenges and solutions. So Dr. Ahmed Al-Hamadi, as we said, is the director of a new multidisciplinary program in Qatar, caring for children with technology-dependent and medical complex conditions. This is the Pediatric Complex Care Program. So these offer coordinated care that spans the inpatient and outpatient divide. Dr. Al-Hamadi has completed his pediatric residency training at the British Columbia Children's Hospital in Vancouver, Canada. That was in 2008. And in 2010, he did his general academic pediatric fellowship at the Hospital for Sick Children in Toronto. Due to his leadership and management skills, Dr. Al-Hamadi was appointed as Deputy Chairman of the Pediatrics Department at Hamad Medical Corporation in Qatar in 2014. And his areas of expertise and main research interests are in pediatrics inpatient care, outpatient ambulatory care, models of care for children with complex chronic conditions, and teaching different learners in multiple busy clinical settings. Dr. Al-Hamadi has publications related to vaccination, urinary tract infections in children, medical education, and other general pediatric topics. Dr. Ahmed has also a strong interest in medical education and supervises residents on the pediatric wards and clinics, while also serving as an assistant program director of the pediatric residency program. Thank you, Dr. Ahmed. The mic is yours. And we can see your slideshow. If you could put it on presentation.
You see
on
it?
Slideshow. Yep, yep.
Can you see my presentation?
No, not now. It was there.
It was there. Sorry about that. Okay, now.
No, you're right.
There you go.
Yes,
now,
coming to us now. And on full screen?
Yeah.
Great. Wonderful. We can hear you well. Thank you.
Wonderful. Thank you very much for this kind presentation, and thank to my colleague who was given the last two. They share with us their experience from different area and from India. So again, Dr. Ahmed Al-Hamadi, my background, I'm a pediatrician, and I'm here to share with you our experience with the postgrad education. I will talk to you about our journey of this workshop, about the promoting effective communication and team collaboration in healthcare, multicultural background, and clinical setting, what the challenges and what's the solution. So the background of this is actually a workshop has been done in Hamad Medical Corporation and later on in Sidra Medicine for all postgrad trainee, mainly for the resident. I'm talking here about the pediatric residents since my background is pediatrics. So we conduct this workshop over the last, I would say, 3 to 4 years and become a mandatory for all residents before they join the program of pediatric, which is 4-year training program. They have to go as a mandatory to this workshop first, and then every 2 years they have to attend the same workshop. So this is the workshop. It's almost 3 hours workshop, sometimes 4 hours. It depends on the time of the resident, but usually 3 to 4 hours. It's a very heavy, long day with the resident. And we start with the resident, actually, believe it or not, but then we move and we introduce it to our colleague, to allied health, to the nurses, and to dietitian, to the social worker. So try to make it more like kind of like interprofessional kind of like collaboration and education. And recently I introduced it also to my faculty. So the senior level, the admin level, the operation level, everybody need to be familiar with these topics. So this is the objective of workshop. What we usually will go over. We highlight why we need the effective communication and multicultural healthcare providers, and then we try to identify the challenges and the barrier with them. And finally, and this is the most interesting part, the last usually 1 hour or maybe 1.5 hours in the workshop, usually we'll go over a lot of like videos, and we share a lot of strategy, a lot of exercise, a lot of real exercise with the resident, with the nurses, with the operation, with the leaders, about any issues related to communication in the hospitals. So usually we start as we always start with any workshop with ice breaking, and because of the Zoom for the last 2 years, we came up with this wonderful ideas of let's do ice breaking through the Zoom. Or WebEx or Microsoft, and usually we'll go over some funny exercise, and we ask them to write letter E in their forehead, and it depends on what you guys how you will write the letter E. Is it something for yourself, self-oriented, or for others to read your E letters? And then we go over the 6 dimension of healthcare system and quality for the last couple of years. Institute of Medicine and many organizations, they came up with 6 dimension of healthcare system. So we went over what does it mean when you work in the healthcare system, whether you are a physician or non-physician. This is for everyone. The safety, timely, the effective, efficient, equitable, and patient-centered. And we go over exercise for each one of those. So this is kind of like ice breaking with the resident and with the team. And later on, we go over more didactic part. So it's going to be a lot of maybe one-way communication. A couple of slides just going over the current medical practice and the change happen in the healthcare system because of that. And we highlight the importance of diversity in the healthcare system and the language barriers and others, and the caring for extremely diverse patients carry the risk of less quality of the care providers. So we go over many definitions, and we go over many kind of like a journey or timeline, what's happened, why this topic is really important in our healthcare system in details actually. And then we share with them some box and something like this. For example, in 2002, the U.S. Institute of Medicine brought the attention to socio-cultural disparity in the healthcare system, and they encourage all of us to integrate the multicultural background, the diversity in our curriculum, in our healthcare curriculum. And believe it or not, and then we go over the ACGME core competency, which is the postgrad competency curriculum. So any resident, any training program, postgrad, they need to have a competency in those 6, which is the patient care, medical knowledge, and system-based learning, and professionalism, and communication skills. So we go over all these kind of things in details with them. And then we go direct to what is communication in details. It's going to be a lot of interaction here. I'm here just to share with you our slide of this workshop. It's, as I said, it's a very long workshop, but we try to summarize it for this presentation and maybe 20 minutes. So we go over many definitions of the communication among healthcare provider. What does it mean? We try to make it really simple to the learners, so sending, receiving information between 2 or more people. And then we focus more on non-verbal communication, especially when you go and talk about multicultural diversity in your healthcare system. There's many things it may happen and you didn't pay attention, some hand movement, some body contact, some postures, some sound, the way you are talking, your appearance, the eye movement, and then we share a lot of exercise with the resident or with the other colleagues who attend this workshop. And then during this workshop, we'll go over many models of communication, some old models and some new models, and we'll share with them the evidence base behind everyone. What does it mean encoding, decoding? What does it mean noise? What kind of noise when you communicate with anyone? Is it psychosocial noise? Is it visual noise? Is it psychological noise? And then we go over many actually recent study, highlight where is the gaps, what's the communication gaps, and how much of the communication will lead to a medical error and others. And I'll share with you here I know this is very old, 1960. They see in what he mentioned in his book that 7% spoken words communication, almost 40% voice and tone, and almost 55% is the body language. This is the element of communication, believe it or not. And if you try to implement or apply the same concept or the same elements, nowadays it's almost the same, especially when you come to the interprofessional or multidisciplinary or multicultural background in healthcare system. And then during the workshop, we go over the cultural diversity in detail. What does it mean? And I forgot to mention, this workshop actually is not myself. I have another 3-4 colleagues from different backgrounds. So I'm here from Qatar. I'm wearing my ghutra and agal, and I have another one colleague from Africa, from Sudan, another colleague is from Egypt, and another colleague is from Europe, and I have another colleague from Canada. So they will see a different facilitators, a different presenter from different background. And sometimes I will go myself as a pediatrician, or maybe I will bring, for example, my nurse educator with me. So so this workshop over many years, there was many facilitators giving this workshop. So again, we go over many definition in details. What is the cultural diversity, and then why the cultural diversity is important, and especially when we as a physician dealing with a patient, we have to remember 3 elements, especially if you're talking about the cultures. Culture of the patient, where the patient coming from, culture of the healthcare provider, my culture, for example, and then the culture of the workplace, where you practice. Practice in Middle East different in Africa, different in Asia, different in North America. So you need to be familiar nowadays as a physician, or even as allied health, pharmacist, social worker. You need to be familiar with all these 3 concepts. And then we go more details in cultural sensitivities. What does it mean? And also we share a lot of examples. And then the healthcare providers, cultural competency. What does it mean for me, for example, as I'm working in the hospital? It means knowing their own culture as well as the culture of other patients, to be sensitive to the patient beliefs, sensitive to patient values, and religious, and learn about their language, adapt their verbal, non-verbal communication behaviors. And then we always share this slide with them, and they love it and they like it. We know we as a healthcare provider, we have our own assessment, our own expectation, our own curriculum, for example, our own training. But also on the other side, we have a patient here, family understanding, family expectation, patient expectation. It's really different. So how can we bridge the gap? How can we really meet their expectation, or make sure we are both talking the same language? Definitely. The key here is the effective communication skills and culture sensitivity awareness. If you don't have good communication, if you don't have the culture sensitivity awareness, I'm sorry, you will have a lot of gaps in your healthcare system, a lot of gaps in the patient care. So this is what really, I would say, this may be the heart of this workshop with the resident. And then we talk about what's the impact of communication in healthcare setting on the patient, on the revenue, on the medical errors, on the satisfaction, and we share with them a lot of study, or recent study has been published. And this is, for example, another publication about the cost. 66% of medical events or adverse events reported because of the communication gaps or lapse. This is, for example, about medication error. Almost 60% of medication error in some study because of the communication lapse or error, interprofessional communication. And then we go over why we need the healthcare, why we need communication in healthcare setting in more details, and we share with them what's the evidence base in the literature, why it's really important in details, and we share with them a lot of recent updated study. Healthcare providers and train in the cultural competency. The literature really shows that they provide better clinical cares and work more effective with diverse healthcare staff, acts as a leader, mentors, and role models for other healthcare providers. And the most important, what I really see, increase the job satisfaction. And the most important in any workshop, when you talk about workshop, of course, is the videos. And a part of the exercise, ice breaking, a lot of role play, a lot of scenarios we share with them, a lot of small group discussion. But because of the pandemic, by the way, we haven't stopped this workshop even during the pandemic. So we are still delivering this workshop even during the pandemic, believe it or not. Every 3 months, every 4 months, myself or my colleague will present this to the resident through the Zoom or through the any other virtual platform. We're still using this workshop as a mandatory despite of the pandemic. So we'll share with them many examples, and maybe I would like to share this video with you. This is the local videos. We made these videos in Hamad Hospital and Sidra Medicine. All the actors here, they're not a patient actually. They are our resident and our operation team and our scheduler team, our patient access, some of them our nurses, some of them our social worker, some of them our pharmacists. So we make this. We made this videos. I would like you just to see these videos and the quality of videos we share with the resident. I'm not sure if the voice will be clear though, but let's see if you hear it or not. Let me know. I hope you will hear it.
Yeah, Doctor, we're not hearing the sound.
You are not hearing the voice. I'm really sorry about that. But this video, okay, you may see it, but
sometimes
maybe
in the audio setting we can fix that.
But you can't see it.
Yeah.
Anyway, so again, this video is very simple.
Dr. Ahmed, I'm sorry for interrupting, but when you share, there is an option for you to optimize for motion and video. If you can see it, it's on the right corner up. There is something called automatically optimize. You can select optimize for motion and video. I can't hear you. You're muted.
Yeah, we're not hearing, Doctor. Maybe you have to unshare and share again? You think, Zena, that would help with
Can you try to share it again?
And optimize for video.
When you click on share content, on the top corner, right side, there is automatically optimize. Select optimize for motion and video. We can't hear you. You're muted.
Now, hopefully you can hear the sound.
Okay.
Yes, that's good. All good.
What's wrong with you? Baby. You're pregnant? I want to know your pain. Which one? Which leg is your pain? Anyway, at this point, which one? Oh no, the baby. Which one? Which pain? I need you to sign this, please. This is the consent, okay? Sign this. Sign here. Sign here. Just sign here to let you in. No, just to let you in. Okay. Can you point to this diagram? Baby! What is this? You have the gown for her? Yes, for her. Did you call the doctor? Oh, please call the uncle. I will call him. What's her nationality? Oh, they always exaggerate the pain for the thing. I will call them.
What happened? What happened? What happened with my sister?
What's wrong with you? I think she has pain or something.
Yeah, she has pain. She's been bleeding for 2 days. I think she's having a miscarriage. This is her 4th time. She doesn't have any kids.
Did you give her any medication for the pain?
We've been trying to give her herbal medicine for 2 days, but I don't think it's working.
Okay. So let me call the doctor, make sure that.
Yes, please. Yes, please.
Hello. What's wrong?
No. She doesn't want a male doctor. You're the doctor?
I'm the only one available.
No, we cannot have a male
There's
doctor.
no another.
Her husband will refuse, completely refusing.
Where is
Cannot
our
have a male
husband?
doctor. He's at work. He will come. We have to wait for him.
You have to examine her. You cannot wait.
It's impossible. No.
Who are you?
I'm like her sister. I'm her neighbor and best friend, but I'm like her sister.
What's the problem with her?
I think she's having a miscarriage. She's having bleeding and pain.
Now she's having pain?
Yes.
Okay, we'll give her some pain medication. I'll let the nurse to examine her also, okay?
Okay. Thank you.
Hello again. So, we examined her. She has a severe bleeding, unfortunately. And we think she has miscarriage. So we have to take her to the emergency, to the theater to do emergency evacuation.
We have to wait for her husband.
No, this is emergency. You cannot wait.
No, استنى. We have to wait.
No, this is emergency. You cannot wait for that.
لا. She's refusing.
استنى.
So, I mean, this is one of the videos, in addition to actually more than 5 or maybe 6 videos we share with the resident during this workshop. But this video really has a lot of communication gaps. And, you know, this is ladies who from different culture came to the hospitals in abortion, and she, you know, nobody know, she doesn't speak English, for example. So the nurse maybe shows some empathy at the beginning, but then things change, and then because of the language gaps between the patient and the nurses, many gaps happen in the patient care, and also she refused to be examined by a male doctors, and this is plus and the other things. Maybe she I think, I'm not sure if she signed the consent or not about receiving the treatment. So there is a lot really to discuss in this video. So usually we'll present the videos and maybe we'll repeat it 1 time or 2 times, and then we'll go over discussion with the resident for maybe more than like 10-15 minutes and try to find where is the communication gaps, where is the lapse here, what's happened exactly, and how to overcome the communication error here and what's happened exactly. So this is basically like what usually we share with our resident. The last part of this workshop usually, or the last 2 parts, related to the challenges and the challenges and the barriers. Is it easy to implement a good to have effective communication and multicultural healthcare system? Really is not an easy, from my experience, very difficult. In Qatar, for example, and I'm talking to you now from Sidra. I was just checking the numbers just like before this workshop in the morning. Believe it or not, we have more than 100 nationalities working in this building. Now, I've been appointed as the chairman of Pediatrics, so I have more than 100 different language people here in my hospital are speaking more than 100 different languages, and they came from more than 100 background. And you know, even the medical background is totally different than anywhere else. So it's really huge, big diversity in our hospital. So then we share with them what's the opportunity if you are working in a multicultural hospital. What's the opportunity? So it's a lot of discussion between us usually and the resident. And here we list some opportunity that may happen. And then we also ask them about the barrier. What is the barriers? It's like therapy is more like a small group discussion. And then we list the barrier for them. Is it personal, communication, culture, learning barriers? And then the last part really of our presentation, of our workshop, focus more on the strategy, tools and strategy. How can we build a good relation with others? What the strategy to use to overcome any communication barriers? And we share with them a lot of tips for cross-cultural communication. And this is one of them. From Marta, and also we search with them different communication tools like SPAR, call out, check back, handoff, learn. And by the way, all these communication tools heavily used in the clinical setting. And we've been able, believe it or not, after this workshop, 3 years ago, now the SPAR communication is mandatory in our hospital. So physician, nurses, they need to talk to each other by using a SPAR technique. This is the SPAR here. So we share with them what does it mean SPAR. We go over many exercises. What does it mean SPAR? We ask them within their small group, within the table, to practice the SPAR. We give them many scenarios and we ask them to practice the SPAR. We share with them many clinical and non-clinical. And then the last part is the team steps. So we focus a lot of our strategy and tools, how to build an effective communication on team steps. So we discuss team steps really in details, and we go over many tools and many strategy. As I said before, call out one of them, and we share the scenario, for example, check back, and we share the scenarios for them. It depends on who's attending this workshop. If it's just physician, we'll focus more on physician. If it's mix of physician and nurses, which is really great, then we share with them all the exercise related to the nursing side, physician side, and even patient side. So this is all the scenarios we share. We share with our attendee or our resident or even nurses. Last one, we also focus on Learn. Another interesting tools has been implemented also in many hospitals and working very well in the hospital. Again, how to break the any gaps and build the effective communication. And then we share the take-home message. Now, what's happened over the last 3-4 years, and this is our abstract. We share this abstract in more than actually 5 or 6 different international and international conferences. Myself, I will present this sometime. My colleague, as you can see, Manasik or Hatem or others, also will go and present this in different workshop. What we did, of course, we did a survey after each workshop. We did a survey, a very simple survey, asking about their perception. Where is the communication gaps? We asked them what their understanding of the culture. What does it mean? What does it mean working in the different cultures? And then we gathered a lot of information from the survey, like a pre and post. We did the pre and post survey, and this is the latest presentation. Just we presented in one of the communication conference 3-4 months ago, and we shared the data with them. So again, the survey shows the workshop objective was met, and everybody who attend, they really have better understanding of the culture background. During this exercise, as I said, we're using a lot of cultural non-verbal communication. So we teach them, even by the way, how to speak in different language. In Urdu, we teach them how to speak in Egyptian language, in Arabic language, and Asian language. So some of my colleagues are really good in doing this kind of communication exercise with the resident. So really the outcome was really amazing over all these wonderful years. The workshop meet the clear objective 90%, enhance the knowledge and also around 85%. So this is one. There is actually more than one. I share with you this. This is one poster or one abstract, but actually there is more than 3-4 different abstracts has been presented in the different national and international conference. So thank you very much again. I don't want to take more time, but thank you very much for your listening. I just really what I did here, just like I share with you what we're exactly doing in the post graduate setting, dealing with the resident from different culture, dealing with the nurses from different cultures. This is really not an easy, a very difficult. But having such a workshop, and we make it a mandatory workshop for the trainee, for the nurses, for allied health, I think it makes a huge difference, really make a huge difference. And I highly recommend and encourage all of you to have something similar, maybe in your institute, in your healthcare system, maybe in your hospital, even in your clinic. I think that will have a great impact on the patient care. Thank you very much.
Thank you so much, Dr. Ahmed. And I'm sure, like me, everyone can really feel your passion for communication and diversity in healthcare. So thank you so much for sharing that with us, and very rich workshop that's been developed by your team. So congratulations to them. Is there anybody who would like to ask specifically questions to Dr. Ahmed about the workshop? If you would like to, please raise your hand and you'll be unmuted. Doctor, I'd be really interested to ask you, you mentioned that sometimes it's all residents, physicians, and other times there are representatives from other sectors, nursing, allied health. As a facilitator, do you see any difference between the dynamics of those workshops?
At the beginning, yes, there was a lot of maybe I will say a lot of difficulties, and as a facilitator, when you deal with the physician, I am physician. Dealing with physician may be much easy for me. When I deal with somebody who's not in my subspecialty, there was a lot of difficulties at the beginning, but over the years of delivering this workshop, I don't see any problem really. I think we are all speaking the same language. We are here for the patient. We are putting the patient in the front, in the center of everything. So no, with time, you won't see any difference between both the group. And what we did for the last 1 year now, almost for the last 4 or 5 workshops, actually we integrate. We both the resident, physician, and the nurses in one room. So nurses, allied health, all of them, they will come in the same room, on the same table. So usually when we prepare the workshop, I will make sure, for example, of 5 tables, 4 or 5, for example, person will be there. One of them physician, social worker, pharmacist. So you're not kind of like interprofessional education and collaboration all the time. So no, we don't at the beginning, yes, but later on, no.
Fabulous. And you mentioned that really having the patient at the center is that factor that helps with that collaboration, yes?
Right.
Yeah, fabulous. That's great. Anyone else like to ask questions of Dr. Ahmed related to this communication workshop?
There are some comments in the chat. Taysir saying this is an amazing video. Dr. Lulu Sherif, excellent initiative and effort by your team. Dr. Hamadi, for a much needed topic. Kudos to your team.
Thank you.
Can I ask a question?
Please.
Thank you so much, Dr. Ahmed. I mean, this is really great. I'm wondering, so basically I work with the College of Medicine here in Qatar University. And as you were just like, you know, going through your presentation, I'm thinking about our students, and I'm thinking to what extent you think we can actually prepare them even beforehand, before they come to you, through these kind of communication and cultural diversity, or once they get there, it'll be easy for them to kind of assimilate and learn at your end. Which one do you think will be better for them and for you, of course?
No, I thank you very much for this question. I think such a workshop can be easily given even in early, like before the postgrad and the undergrad. Actually, that would be a very good introduction. Even when they do the, like, you know, when they go for the clinical services, I think in year 3 or year 4, before they join us in the hospital, I strongly believe they need to go over this kind of like workshop, communication skills, interprofessionalism skills, interprofessionalism, collaboration education. They need to be familiar really with all these concepts and how to deal with those different culture. What to do when you face this problem, whether patient or your colleague from different culture. So yes, I totally agree with you. I think this needs to be a part of their curriculum, need to be really integrated in their curriculum before they join us.
Absolutely. What I love,
and we are more than happy, to be honest, we are more than happy to deliver this workshop to Qatar University. Anybody interested, we're more than happy, really, myself and my colleague. I mean, we can work with you very closely, and you know, either we come to you guys, or maybe you guys join us and come to Sidra or Hamad Hospital. I think we're really flexible either way.
Our pleasure. Thank you so much. What I love the most is like, you know, the same lingo. Like there's a lot of communication skills and cultural diversity. But what I love the most was that, you know, you're speaking the same lingo. So you have like, you know, the stem, da, 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 da. So basically when I say this, they use the same lingo, and that's what makes communication much easier within that such a diverse. So thank you so much, Dr. Ahmed. Thank you.
Okay, yeah, I think we have another question. Dr. Lulu, I strongly believe these concepts should be introduced into the foundation and induction courses of all healthcare professional courses for the undergraduate. Yes, for sure. Like these are important concepts, you know, to be introduced and then practiced later on. And I think what I found interesting, it's, you know, here in Qatar, it's quite an interesting environment. So it's a multicultural, interprofessional, and international, you know, with people coming from different parts of the world. So there are a lot of complexity, a lot of, you know, that comes within, especially when you want to practice interprofessionally. And I think this is actually something interesting. Sometimes we look at cultural diversity, we look at being interculturally competent, but I think also thinking about it from an interprofessional perspective is really important as well. What do you think, Susan?
Well, I was going to say, because, you know, there's a famous saying that culture eats education. So, you know, we can try and educate and talk to people, but, you know, I was thinking even about, you know, the previous speakers and the things that they were doing, that, you know, that idea of sharing communication techniques and discussing cultural diversity can really bring people together to understand their own role and other people's role and how they work together. So I think having culture as the basis for what you're trying to develop can really be a positive step forward in creating, you know, the development of interprofessional capability. I think that's a wonderful, rich context in which to do that. Yeah.
Mm-hmm. Like I'm wondering with Dr. Lulu and Dr. Supriya, like in India, yeah, it's yes within the same country, but there is also you know, different cultures as well. So I don't know if this is something you know, that you come across.
Yes, Dr. Alla, I would like to congratulate Dr. Ahmed on a wonderful presentation and a very important topic. It's the crux of interprofessional education, rather communication. And in our scenario in India, we have so many languages, so diverse is the population in India. So it's a huge task, rather, navigating around and bringing in communication, proper communication. So I think
many languages
Lulu,
do you have? How many languages?
we have around many states. Okay, and each state, for example, I'll take Karnataka, Mangalore, where I'm in. We have 3-4 languages in Mangalore itself. So a person, but since English is the official language, we can navigate around a lot with English. But patient communication, still, you need to know the basic language which is for that area. So in Mangalore, there's a language called Tulu, and there is Konkani. So depending on the where the patient is from or which community he belongs to, the language varies. So it's a huge task. It's a huge task communicating here. So it's not that easy. Dr. Lulu can actually come in.
No, just to follow up on what Dr. Supriya mentioned, for us, language is a huge barrier, and that's what we are trying to inculcate to the students right from their foundation course. The regulatory body in India right now, which earlier used to be called Medical Council of India, right now it's National Medical Council, the NMC, they have introduced the foundation courses and teamwork, working in a team, and communication. for the first time is, a part of the curriculum, and it's high time. Even though it's the first time, it's high time. But that hopefully will make a huge change in what's happening, especially with the scenario right now, not just the language, but we have religion, caste, we have too many other complications, including hierarchy and a lot of social elements like abuse to the healthcare professionals, want of resources, the poverty line, and so many things are complicating right now, and to teach them professionalism. This is where actually the interprofessional collaboration makes a huge role. In our rural health center, you have one physician and one nurse. That's it. And probably in most rural centers, the nurse is the lead. And this is where we want patient to be a part, and the autonomy, their right to decide what's good for them. There are so many elements in this, and that's why Dr. Al-Hamadi, I mean, workshops like these are a must right now. Like he mentioned, where we need to orient our healthcare professional students on what to expect, not just learning in their own colleges, but this is all what we need to expect other than the technical skills, what they are learning and their own professions. So yes, much warranted.
Yes, medical scenario, the NMC has brought in the competencies like ethics, communication, and these are new things which has come in as foundation courses. But the dental scenario is still the same. So we need to bring in a lot of change, rather. Empathy is something which is really has to come in now.
And I think the other thing that you have all demonstrated is the importance of facilitation when you have a group with many different learners and coming from different cultures as well too, or different disciplines. So maybe you could comment on, what aspects of, well, I think Dr. Ahmed said having people from different diverse cultures is helpful to reflect the audience and the patients that we serve. Are there other aspects of facilitation that, you find helps with that interaction?
So what I would strongly recommend, and we have experiences where facilitator training, that is a key goal in what we need to achieve. All the facilitators conducting and implementing these workshops should be having the same shared mental model. They need to go through these workshops as a learner first, and then they should be able to provide, because then their own perception of on the other side of the classroom on how it feels will greatly impact on how they facilitate such workshops. And facilitator training is a much warranted criteria we need to look at, because most of the faculty who are teaching now in medical schools or dental schools or nursing schools, they themselves have no idea about collaboration and interprofessional competencies involved. What are the role, I'm dealing, one patient is being looked up to by so many people, but I have no idea what the pharmacist is doing or what the dietitian is doing. So, and there's a hierarchy that is, so I don't think it's just in India, I think it's globally, that hierarchy of, the physician hierarchy or the surgeon hierarchy or the neurosurgeon hierarchy. So that is something, we need to break away, especially in such facilitators. They need to be trained on these competencies. And the second thing is a proper lesson plan. When we have a universal lesson plan on what our objectives are, so many things to teach in one workshop. But when we have a proper lesson plan on what our objectives are, what are the TL methods we are going to use, and as a strong advocate of simulation, one beautiful potential to, all the domains which y'all are talking about, communication, professionalism, empathy, ethics, role plays, videos, so many resources we have. And it's not easy. We need somebody as passionate as Dr. Al-Hamadi, and passion is something that comes. The returns are nil. The only thing is keep the patient in front. Tomorrow, you can happen to be the patient whom the student is operating on, so you better teach your students properly. So keep the patient in front. So these are a few things which we need to drill into the facilitators. So I think that is what I would suggest.
Yes, I agree with that. Training the trainers, basically.
Yeah, thank you.
That's very important.
And I think as you're demonstrating, you know, role modeling that respect for each other's disciplines as well too, and the value of working together. I mean, you know, those things are really important part of that training that you're speaking about, Dr. Lulu. So very, very good point. Any other questions from our audience? Everybody is reflecting on all the wonderful things that you've shared with us. And I think the last point that we just heard you say, Dr. Lulu, about you know, putting the patient at the front is something we can all identify with, because certainly the service user or the patient, the client, they expect us to know what else is happening and to understand our colleagues' roles, don't they? So yeah, I think this is something that we need to keep in the front of our mind as well too, that there is that expectation that from our patient that, you know, we're all working together and understand each other, and can be very disappointing if that's not their experience.
Yes, for sure. And I think also like, I think it's very, very important that those who are going to be the facilitators, you know, as mentioned earlier, train the trainer. So they are the role models. So, you know, people are going to be looking at them as role models for collaboration. So they need to practice this, you know, with the preparation for you know, for the workshop, for the activity, for the event, ensuring that all the different shared competencies are really implemented before delivering this to you know, to the participant and to attendees for sure. Like, I think this has been really interesting, you know, like really some exciting you know, experiences from India, from Qatar. So yeah, thank you so much. And I wonder if there is any final messages you would like to share on way to go forward. I know you've shared some recommendations, but like, what's your plan next? So anyone can start.
So since I presented first, I will conclude first. First of all, thank you so much to all the organizers and the presenters, and definitely the participants who have reached out to us, you know, asking for resources. So this is the way forward is, one is advocate interprofessional education first, so that we all can practice collaboratively and, you know, keep the patient safe and improve the quality of care. And second is, like Alla mentioned, there is no point you talking in the simulation center and, you know, saying something and the students are seeing you practice in the clinic, totally different with the nurse. So role modeling is hugely important. So that's it from my side. Thank you so much to everyone.
Thank you.
Yes, I would like to thank the organizers for this wonderful opportunity to talk at this forum. And I'm very passionate about getting the mouth back into the body, rather. So that is my ultimate aim. Like, it is in a completely two different silos now. So that is the most important thing. And if I can get that back into the healthcare learner education system, I'll be really happy. Thank you. Thank you so much.
Yeah, thank you very much. From my side, I would like to again thank Alla, and thank Susan for the wonderful webinar. I think from my side, we can definitely go from my specialty, which is pediatrics, and move forward and take this program to another discipline, like internal medicine, like the surgery, like, you know, OB and gynae, like all other discipline. I think they need to be involved, need to attend this workshop, and so expand more within the postgrad. But also, I think we should work together with Qatar University and maybe move this workshop to the undergrad, especially in the 2022. Maybe we can work together with Qatar University, and I believe they will get a lot of benefit from such a workshop. The other things I'd like to share is the leadership, like the leadership, you know, those the manager, the CMO, the CEO, those the C-suite, they call them the C-suite. When they maybe they need to attend such a workshop, and maybe they need to be a part of this communication within their employee. I think that will make a huge difference to understand everyone in the hospital. Just try to build the team. I mean, we are all here for the patient. Let's work as a team, one team, and improve our communication. So yes, my next step, expand more in the postgrad. Undergrad, we are really more than happy to expand more and more. I think we have to involve our leader, our C-suite to attend those workshops.
That's amazing. Like I can see how passionate, you know, the three of you are about, you know, IPE. And I feel actually the passion for IPE is very infectious for sure. So yeah, so keep up this amazing work, and I'll leave the final words to Dr. Suzanne.
Thank you, Alla. I appreciate it. And thank you to our three wonderful speakers who really shared with us their great passion for working and learning together. We can really be inspired by your experiences. And I think in your concluding comments, that's all helped us as participants to think about how we are going to go forward as well too, to support our students and our colleagues to work collaboratively together and to understand each other. So thank you so much for sharing your experiences, and thank you everybody who participated in being here today and for the questions that you shared with us. We look forward to coming to Qatar in 2023, inshallah. And thank you very much, Dr. Alla, for putting this on for us today.
Yeah, thank you, Susan. It's been really a pleasure having you with us. Really, your valuable contribution is really highly appreciated. And thanks to Zaina, you know, for wonderfully, for all her great effort in organizing this.
Absolutely.
Until we meet again, thank you again so much. And we'll be sharing with you the recording for everyone who has participated. And inshallah, we'll see you soon. Assalamu alaikum.
Alaikum salam wa rahmatullah.
Thank you all.
Thank you. Good afternoon. Good evening.
Thank you so much.
Thanks, Dr. Supriya.
Same to
We're
you.
always going to think about the mouth in the body, definitely.
Thank you. Thank you. Thank you, Alla.
Thank you so much.
Bye.
Thank you, Supriya.